Hello everyone and welcome to today's presentation by Dr. Leslie Savella. Dr. Savella is a haematologist based at Royal North Shore Hospital, previously worked at POC INR in Pathology West and is responsible for the laboratory services of over 30 sites within Western New South Wales, including point of care. She's very interested in ensuring good diagnostic services are delivered to patients in remote locations and ensuring there's a good interface between point of care users and patients, and the support these services provided by the laboratories to ensure we deliver the best quality of service to our patients. And I've also personally had the pleasure of working with her during my time at POC INR also. So I'll hand it over to Leslie right now. Thank you, Leslie.
Thank you, Dora, and thank you, Julie, and hello, everyone. It's a great pleasure to come and speak to you today. I'm actually one of the pathologists who sits on the point of care committee. I have a real interest in this area, and it's very exciting to see a service developing that is actually now going to be delivering world quality care to our patients in remote regions. Previously had to rely on a lot of things being sent away. A lot of those things are now getting done at the bedside, as you know. So what are we going to be doing today? I've got a number of learning objectives listed. I've had a talk to quite a few of you. You've spoken to me about what you're interested in hearing about, and hopefully we can try and cover it. Now, since the creation of the point of care group and point of care as a service, a lot of the things that we used to do in the laboratory are now getting done at the bedside. So we need to impart some of the knowledge about how and why we do things in the lab and what the tests are about and how we make sure that they're accurate. And at the same time, we've got the great pleasure of getting all of you with your clinical connections coming into the laboratory as well. So I really think this is actually taking a lot of the barriers down between us, and hopefully we get a greater understanding of each other, what we need and how we work and how we help each other. So what I want to do is try and explain to you a little bit about what the INR is, and then have a look at the differences between the INR that's being done traditionally in the laboratory versus the INR that we do on point of care instruments. And I know a common question is, why are they sometimes different? And so I'll be talking about that as well. There's also different point of care devices out there. So I'm going to talk a little bit about the two that we use commonly. So I can hear some of you in the background. If you haven't muted your computer, could I get you to mute it? Otherwise it comes as feedback to everybody in the group. Thank you. So I'd like to talk about the difference between these point of care devices, and before we even put them out there for you, how we actually assess their reliability and make sure that they're fit for you to use. There are factors, both in the way we collect blood, how we do the testing, and also factors in the patient that can affect testing that you need to know about. And I'll be imparting a little bit of the laboratory secret knowledge on that sort of thing. And then we need to understand some of the limitations of testing. You know, what are the limitations of the instruments per se? Every test has limitations. When do we retest, or when do we actually refer that patient for formal laboratory testing? So without further ado, we'll start, and hopefully we'll address some of those issues. So I'm sure many of you involved in point of care have seen this map before. I think it's really exciting to see all those little dots on the map that represent point of care services, and look how far they are going out into the country, probably in many places where we didn't have laboratory services before. This is in fact the largest point of care service in the world. New South Wales is really leading, and because we are leading, we are becoming influential with some of the developers who are working around us and developing instruments to meet our specifications. So I think we have a lot of opportunities. There's now hundreds of sites involved, and I think we had 22,000 users trained when we last looked at this. And as you know, the number of point of care tests there's a limited number of them, but technology is driving in this direction towards miniaturization, and I can only see that this is going to expand and that more tests are going to become available at the bedside. So this is a very exciting opportunity for you to provide diagnostic services to your patient right when you're seeing them. Okay, so I think Dora mentioned that when I was working at Pathology West, I used to supervise 30 laboratories, and some of my most remote laboratories were out in Walgett, which is circled on the map, and even north of that was Lightning Ridge, which didn't have a laboratory but a little point of care service. And this isn't actually my photograph, but it's in the top left is a typical picture of the small fixed-wing aircraft, six-seater, that I used to fly in with the Flying Doctor Service to get out to these locations. And we used to fly over miles and miles of undeveloped countryside or farmland, really, until we got to these little points in remote outback New South Wales where there might be 2,000 or 3,000 people living and a small hospital with limited diagnostic services. And that's a picture of Walgett that you're seeing on the map. So, it goes without saying that we are putting services in areas that are very isolated. If you have to send samples to a teaching laboratory in Sydney from places like this, it can take hours. We are still referring things like blood films, for which we need a senior diagnostician to look at some of those when they've got complex problems, and they can take 1 to 2 days to arrive in Sydney. So getting tests done where you need them, when you need them, is the whole reason point of care exists. Okay, so now I'm going to talk to you a little bit about what is the INR. And to understand what the INR is, the first thing you have to understand is what are clotting tests. Now, the two clotting tests we use to assess patients are essentially the prothrombin time, or PT, and the activated partial thromboplastin time, or APTT. I'm only going to be talking about the PT today because it is the basis of the INR. The INR is just a modification of the PT. So I'll see if I can get the little arrow working. Oh, hang on. Yep, there we go. So if you take a test tube of patient's plasma and you add thromboplastin, which is a reagent which represents tissue factor, which is the tissue factor exposed when somebody injures themselves, and then you add calcium as well, you actually cause a clotting reaction to occur in that sample. And what happens is the extrinsic clotting system is activated, represented by this little blue circle, and then the common factor is activated. And you don't need to know any more detail than that. But finally, we get the conversion of clotting factor 2, prothrombin to thrombin, and clotting factor 1, fibrinogen to fibrin. And fibrin is what forms the basis of a clot. If you get fibrin plus platelets clumping together, that's actually what causes a clot and stops you bleeding at the site of the injury. Now, we measure that PT, or prothrombin time, by the time it actually takes your sample to clot. And the way instruments usually do this is by seeing the clearing of the plasma as the clot you can detect a change in light going through a sample when the clot actually forms. And so we're actually testing for a time to clot. Now, the INR. So the INR stands for the International Normalized Ratio, and it's just a calculation, and it's calculated from the prothrombin ratio. And essentially, in the reagents that we use in the laboratory, we receive a little correction factor that allows us to correct for the thromboplastin reagent, which is the reagent that helps the plasma clot, and the instrument you're using. And the point of that is to correct it to the same result that we would actually get if we used the same instrument and the same reagents in every laboratory. So it really does try to standardize the INR so that the INR in laboratory 1 is the same as the INR in laboratory 2 and is the same as the result you get off your point of care analyzer. Now, why did we actually do that? Before we had the INR, we used to work off the prothrombin ratio to actually correct patient's Warfarin dose, and you would find patient would go to laboratory A and then would travel a bit and go to another laboratory, and the results would be completely different. And so doctors would change the dose based on that, and there was a lot of variability in dosing and obviously overdosing and underdosing of patients. So this whole process of developing an INR to correct the prothrombin ratio was a patient safety measure to make sure we got the same result everywhere. Now, has it worked? By and large, it has, but you'll still see a bit of variability between laboratories because it's not 100%. So we still say to patients who are having their INRs monitored in a major laboratory that they should go and have it done in the same laboratory every time. And the same thing actually applies to point-of-care instruments. If you're having your INR measured on the point-of-care instrument, you have a particular instrument and you have a particular thromboplastin that is being used, and you may get a slightly different result to if the patient had the same sample taken to a laboratory and tested there. And that's why we like to do it on the same instrument all the time. Okay. So how do we do a point-of-care INR? I'm just going to put up another slide. So sorry, this one actually tells us the same thing we've looked at earlier. Sorry. We're looking at mechanical clot detection on the laboratory instrument. Now, what about on these other little point-of-care analyzers? So there we go. We're looking at a clot. The point-of-care principle of the INR is pretty similar to the laboratory instrument, except instead of it being in a test tube, we've got a reagent strip, and that reagent strip contains that thromboplastin or tissue factor and a little peptide or protein substrate. And when we apply the sample to it, the thromboplastin, like it does in the test tube, again activates coagulation, and that leads to the formation of thrombin. And then the thrombin, which is an enzyme, cleaves the little peptide substrate on the strip, and this generates a slight electrical current which is picked up by the instrument, and that's converted into an INR on the instrument, and it's the same principle for both the iStat and the CoaguChek. Now, some people have asked, well, it's a different method to how we've always done INRs. Is it suitable and is it safe? So when we're doing this in a laboratory, we go through a number of processes to make sure that the new method we're going to use is going to be comparable to the old method, that we're going to get similar and safe results, and that it's going to be safe for use in patients. And the first thing we do is we will take maybe 20 or 30 patients, and we'll do them on both the old instrument and the new instrument, and then we'll compare them, and we'll do what's called a correlation graph and see if we're getting very much similar sort of results. The next thing we'll do is we'll make sure that we are controlling the quality of what is being produced. So part of that is to make sure all of our users are trained in a standardized fashion and are competent, because the biggest source of error in any test is technical variation in your users. So it's really important to get our teaching and training and competency up to speed and make sure everyone knows what they're doing. And then once we've got that controlled, we will then run quality control tests before the operation. So these are little samples where we know what the target value should be, and we want to make sure when we run those target samples that we're getting the results we should. And in addition, we also get some samples that we receive from an outside laboratory. In this case, the Royal College of Pathologists sends out some samples of an unknown value, and they ask you to analyse that, and they have a look at what you get, and then they compare it to the median result for all the laboratories who are doing the same thing and make sure you're within the target range. So first of all, validating that the instrument is a correct way to do the test, and then controlling our training, competency, and our quality control are very important. So I'm going to show you what we've actually done for these instruments and some of the results we get for the quality control we're enrolled in. So this is the little CoaguChek instrument, and what we've got, sorry, just wait for the little arrow to come up, is the CoaguChek on the y-axis and our traditional method, which would be the laboratory test on the x-axis for the INR. And you can see that when we have an INR of, say, 3, we're getting on the laboratory instrument, we're getting a very similar result from the CoaguChek. And that occurs for all points, so low INRs, an INR of 2. So this is basically a straight line through these results. And an ideal correlation on this line would be a slope of this line of about 1. And you can see it's 0.97, which is very close to 1. So in other words, we have a very good correlation between the CoaguChek and the traditional laboratory instrument. So if I saw that and I was changing methodology in the instrument, I'd say this instrument performs well and it's fit for purpose and we can actually use it because it's going to produce the same result as I'm getting currently. Now, you can see that the linearity has only really been looked at to an INR of 4, so we wouldn't say that the instrument was fit for purpose beyond that. We don't have any points except for that one, so we can't say how the instrument is performed, and this is one of the reasons we tell you don't use it for samples that have a higher INR, and I think that's also the advice from the manufacturer. What actually happens with some of these instruments is the linearity falls off. So we would say there's a linear relation here between the two values, but as the results maybe go higher, I don't know whether they tail off. Often what happens is they start falling away. So the line drops away and flattens out. And so a result becomes unpredictable to some extent above that level. So we use it up until an INR of 4. What about the iStat analyzer? We've done the same thing here. You can see, sorry, it takes a while for the arrow to appear. You can see that we've actually got a little bit more variation around the line, and that's reflected in a slope that's not quite as good. It's 0.82. It's not, so it should be around 1, but that is still acceptable for use, understanding that every now and again you might get a few outliers with this instrument. It's not quite as reproducible as the CoaguChek. Okay. Right. What about training and competency? I've already said how important I think this is. It's absolutely an essential part of running a reliable service. You wouldn't ask nursing staff to insert cannulas or take blood tests or prescribe or give medication without training them, and the same goes for doing laboratory tests. So only trained and competent users should be able to operate these point-of-care devices, and we need to have a whole documented process of training and sign-off. And because we want the training to be the same everywhere, we've standardised this, and it's been developed and endorsed by New South Wales Health Pathology. So what about reliability of these testing? So there are some things that can affect your testing, and I want to introduce to you the concept of pre-analytical issues, analytical issues, and post-analytical issues. So pre-analytical issues are the things that may affect the test that must be controlled. So this is the way you collect the test, whether you use an anticoagulant, etc. The analytical factors have to do with the instrument maintenance and as well as the QC and quality assurance. And post-analytical is about recording the results, interfacing the results, so making sure you don't get an error between getting the result off the device and writing it in the patient's records and then actioning it. So just a little bit more about pre-analytical issues. These basically relate to either the sample or the patient. So sample issues that can occur might be contamination, or you might have collected the sample into an anticoagulant when you're meant to use a capillary sample. We're talking about looking at the effects of enzymes when we're talking about clotting, and enzymes, as you know, are susceptible to temperature and they also decay. So if you delay in doing the test, the enzymes can go off. In terms of patients, we've got some things that interfere, and antiphospholipid antibodies are one. These are inhibitors that are not that uncommon, and they cause clotting times to extend. Extremes of hematocrit are important because if the hematocrit, which is the amount of red cells in the solution, is very high, there's less plasma to react with the thromboplastin on that little strip, and it actually can give a falsely low result. And the same if you've got a very low hematocrit or red cells anemic patient, it can falsely extend the clotting time. High bilirubins, high triglycerides, hemolysis can all interfere with this test as well. And so the golden rule I as a physician have is if I have an unexpected result, I would generally repeat it. And I'd repeat it using my point of care. And if I still get a result I don't believe or is unexpected, I would actually send that away for formal testing. And I don't think you can go too wrong if you follow that. Now, a little bit about quality control. There's two types of quality control. The first is the quality control that you run on your instrument before you use it. And this is where we use a sample of a known value and we are aiming to hit that target range for that control. And this is all about reproducibility. When I do the test, do I get the same result I got yesterday that I got a week ago? Can I reliably expect that the patient result is going to be the same if I did it yesterday or a week ago? Is the instrument working as it actually should? And you've got all the materials there on this little screenshot. You need the analyzer, the test strips, and the patient control vial and the little pipette. And I'm not going to go into the technical issues of how you do this, but there are some technical staff here if you want to ask questions about it at the end of this. When we switch on these little analyzers, they also do a little internal electronic check of themselves as well. The CoaguChek checks the electronic components of the instrument and its functions, and it looks at the test temperature, strip temperature, and it checks the expiration date. The iStat just looks at the electronic components. So they're both doing a little, am I working sort of check beforehand as well. Now, why do we then, after we've done this, also have to do quality assurance? So quality assurance in the laboratory is really important because it's the only sample we receive to test that instrument where we don't know the value. We don't know what to expect. And in fact, it gives us a reasonable assessment of what an accurate result is. So these samples are of unknown value. We analyze them as we would any other sample on an analyzer, and we send it away to this external body, the RCPA Quality Assurance Program. And what they do is they analyze samples from all the laboratories, come up with a median result, and then they calculate where we sit in relation to that. And we should be in the same range of them. And mathematically, they'll calculate an acceptable range for that result and whether our result is acceptable or not. And a pathologist will review that as these results come in together with some scientists, and they'll just keep an oversight on your instrument to make sure it's performing as it should. And I believe that's all happening through Hunter Pathology at the moment. So all of you who are participating in this, people will be oversighting your results to make sure your instrument is actually, you could say accurate, or you could say close to median, but to me, it's almost an assessment of accuracy. So this is an example of some of the quality assurance that you probably don't see. Is that reasonable? Yeah, it doesn't get seen by you. But people have asked, how reliable are these tests? So this looks like a very complicated picture, but I'll just go over it and show you what I'm looking at. First of all, this is for a CoaguChek instrument. And these little boxes here are our method, people using electrochemical methods, and people using strip reagents. And the best method, the best box to look at is actually this one. This is the one I usually look at. The other one is all of these points. So what is actually happening is 6 times in a cycle of assessments, paired samples are going out, and we are then assessing them and then sending our results back and being compared to the median. So you can see this one here, 2 samples were sent out in this month. It goes out once a month. And the average for all the laboratories on the INR was 2.3 for one sample and 2.5 on the other. And we got 2.4 for the first sample and 2.5 for the second sample. And so you'd have to say that's pretty darn good and highly acceptable, and I would give that a big tick as the pathologist. So then you can do the same with all of the other results. The result for our laboratory was 1.3. The median result from all of the laboratories were 1.3. Excellent. The other result was 3.1, and we got 3.1. So the aim of the ICPA is to try and send out samples over the course of this cycle that represent the range of samples you're likely to see. You like to see people at the lower point of the INR and at the higher point of the INR, so that you can say that your result is linear over the range of test results that you're likely to get. So, sorry, the arrow just keeps disappearing. I would then look at this little box, and another way of representing that is with this box. These little white lines represent the range of acceptable results for the analyte at different INRs. So this is at an INR of 1, this is at an INR of 3.6, and we're comparing our result to the average for all the laboratories, and we should sit in the middle of that somewhere. And you can see these little crosses are our data points, and we're sitting right around the average for all the laboratory, from INRs all the way from about 1.2 all the way up to 3.8. So we know that our instrument is performing acceptably compared to other laboratories, and that we have a linear response, so we know that the result is accurate. Right. I'll just go on to the next one because I've got a similar one for the ISTAT. So that was the CoaguChek, and now I'll look at the ISTAT. Now, somebody pointed out to me that we changed methodology halfway through this. So this is your method here. This little code tells you you're using a particular method, and you can see that for the last 2 surveys in this cycle, we used a different method. So what happened here is a CoaguChek was being used, and then the laboratory switched to an ISTAT. And so it's being labelled as an ISTAT port. But for the first 4 of the 6 paired samples, we were using a CoaguChek. And so when that actually happens, the linearity is not as useful to look at, because you've changed instruments, and that might have been quite acceptable for this instrument. However, say it was all one instrument. If you saw something like that, you would say that the instrument was under-reading results a little bit compared to what it should. However, I don't want you to get concerned and think that's the performance for the ISTAT, because this is not an ISTAT full 6-cycle curve, and we don't have the results, and the ISTAT does actually perform pretty well. Right. So the other issue I wanted to talk to you about is why we sometimes get nonsense results. Quite often it's a pre-analytical problem. So it's an issue that's come up before the test was actually performed. So we've got an example here of a patient with an unexpected INR result of greater than 8. And previously they've always had results of 3 to 3.5 and been pretty stable. So if you saw that, you'd go, that's out of character for that patient. You'd obviously talk to them, get the history, make sure they haven't overdosed or done something different. And if they haven't, and you've got no explanation, and in any case, you would rerun this and make sure that result was actually correct before you action it. And when we reran the sample on a capillary sample this time, the result was 3.5, which was actually the result we were expecting. And it turned out that blood had been collected into a blue citrate tube, and the point of care test had been run from the citrated sample. Now, the problem with doing this is that the citrate will actually bind the calcium in the tube, and that will actually prevent it from being available to act in the clotting cascade, and that will lead to the clotting time being extended, which was the cause of the false prolongation of the INR in this case. So it's an example of we must have the right sample for the right analyzer, and you cannot use the laboratory collected samples for doing your point of care. All right. What about what are the indications for the use of a point of care INR? I believe when these were first introduced, you were mainly using them for acute patients, and some people have asked me whether they are suitable for the monitoring of patients on warfarin. I must say, as a haematologist, a lot of the early work that came out on point of care INRs was about monitoring of patients on warfarin, and it was thought to be a very reliable method of doing so, particularly at that time when administered by patients who became very used to doing the test in a repetitive, reliable way and could get reproducibility of their results. In fact, hospitals and multiple users with potentially changes in technique would have been, to my mind, a non-ideal place to do it, really. But the fact that you're actually getting pretty good results with your point of care shows that you've actually got on top of that problem with training. So it's suitable both for monitoring long-term patients on warfarin therapy, so long as their INR is less than 4, because we know that's where the instrument is linear to, and also in patients requiring urgent results without a lab or an after-hours service where people have been trained. It is sensitive to extrinsic pathway factor deficiencies, so you can use it as a screen, but again, it has limited linearity and you should only use it as a screen, and the test should be confirmed formally. And a normal result does not exclude a factor deficiency. So if you have a patient with a bleeding history and they come back with a normal screen on the point of care INR, you should still go and do formal coagulation tests. It's not indicated for anyone with an INR greater than 4. It doesn't work for patients on these novel oral anticoagulants, rivaroxaban, etc. It's just insensitive to them. And it shouldn't be used for patients who've had snake bite. It's insensitive to fibrinogen and to fibrinogenylysis as well. So you need to do formal laboratory testing for those patients, and doing anything on the point of care INR could be very misleading. Now, when do we need to perform laboratory testing? I've got this at the head of every page. If the INR is greater than 4, clearly you need to do a proper lab test. And secondly, if there are any patient preanalytical factors present. So if the patient is jaundiced, or if you know they have a lupus anticoagulant, if they are very anemic or polycythemic, or if they have severe hypertriglyceridemia. And also to confirm any unexpected results. I think Brian Heffernan was asking me about whether we could infer there might be a lupus anticoagulant on somebody on warfarin if we had an unexpectedly high result, or there was a big discrepancy between the point of care INR and the laboratory INR. And I don't know if it's predictable. You know, these anticoagulants had variable effects on INRs. I think it's actually good practice if somebody is being put on warfarin for them to have baseline PT and APTT in the laboratory to make sure they don't have any inhibitors or coagulation factor deficiencies present before you put them on warfarin. And that's what I always did when I was working more clinically. So I would include that in my clinical practice. So just to summarize, the INR is a test we use to monitor warfarin. That's specifically what it was developed for. It was developed to allow results to be compared between laboratories and instruments and to allow us to manage patients safely. Having it available on a point-of-care device is fantastic because it makes instant testing available at the bedside, and it overcomes distance and resource issues. And as you can see from what I've shown you, we've validated the testing that you're using against our traditional laboratory testing methods, and it performs very well. And I'd be very happy to have my own INR done on it if I was on warfarin. A very important key is staff training and quality control and insurance to maintain that good results that we're getting off the analyzer. And it's important to understand that there are some technical and biological issues which can interfere with the result and cause a poor result. And I think you've taught how to deal with that when you get taught some troubleshooting on the instruments. We have some policies for escalating the INR to the laboratory for formal testing, but in general, if you get an unexpected result, it's a good practice to do that. And if in doubt, and if you're having problems, you have a lot of very knowledgeable point of care coordinators around who can be contacted for advice. You might contact the laboratory associated with your service, and if needs be, if there's a clinical issue, you can speak to the registrars or haematologists associated with your service for advice as well. So with that, I might just end there, and we'll see if there are any questions.